Hey everyone, welcome back to Medmorph. Today, let's approach a very common clinical problem, acute low back pain. Meet Mr. Ramesh, a 42-year-old bank worker. He comes to the outpatient department with low back pain for the past 2 days. 2 days ago, while lifting a heavy bucket, he suddenly felt a catch in his lower back. The pain is mainly in the lower back and radiates slightly into the buttock, but importantly, it does not travel below the knee. He has no major medical problems, but Ramesh is worried. He shows you an old x-ray and says, "Doctor, please order an MRI. I think I have a slip disc." So what should you do first? The answer is not to immediately order an MRI. Your first job is triage. You need to ask yourself one important question. Could this be something dangerous? When assessing acute low back pain, first look for red flags. There are 4 major categories to remember: cauda equina syndrome, infection, malignancy, and fracture. First, ask about cauda equina syndrome. Ask about urinary retention or loss of bladder control, saddle anesthesia, bowel or bladder dysfunction, and progressive neurological deficits. If cauda equina syndrome is suspected, this is an emergency and requires urgent evaluation, usually including MRI. Next, think about infection. Fever, recent spinal procedures, immunosuppression, or other risk factors should raise suspicion of spinal infection. In India, spinal tuberculosis is particularly important to remember. Persistent back pain associated with fever, weight loss, spinal tenderness, or neurological features should make you think about pot spine. MRI is an important investigation when spinal tuberculosis is suspected. Now, consider malignancy. Previous cancer, unexplained weight loss, and persistent or progressive pain are important warning features. Finally, think about vertebral fracture, especially after significant trauma or in patients with osteoporosis risk or prolonged steroid use. After screening for red flags, perform a focused neurological examination. Check motor power, sensation, and relevant reflexes. Then perform the straight leg raise test, or SLR. A positive SLR means reproduction of typical radicular pain during leg elevation, commonly between about 30 and 60 degrees. The important point is that simple tightness behind the thigh is not considered a positive SLR. Now let's return to Mr. Ramesh. His power is 5 out of 5. His sensation and reflexes are normal. His SLR is negative. He has no red flags. So, what is the most likely diagnosis? Acute, nonspecific mechanical low back pain. Now comes the question that patients commonly ask. Should we order an MRI? For Ramesh, the answer is no. In uncomplicated acute low back pain without red flags or significant neurological deficits, routine early imaging is not recommended. Why? Because MRI can show disc bulges, degenerative changes, and other age-related findings even in people who have no significant symptoms. These findings may be incidental and may not be responsible for the patient's pain. So remember the Medmorph golden rule. Don't treat the scan, treat the patient. Now, how do we manage Ramesh? First, reassure him. Most acute, uncomplicated low back pain improves substantially over the following weeks. Second, keep him active. Prolonged bed rest is not recommended. Encourage normal activities as tolerated, and light walking can be helpful. Heat therapy may also provide symptomatic relief. For pain, if there are no contraindications, a short course of an NSAID, such as ibuprofen or naproxen, can be considered. Patients at increased risk of gastrointestinal complications may need appropriate gastroprotection. Avoid unnecessary opioids and don't routinely use muscle relaxants unless there is a specific indication. Let's put the entire approach together. A patient presents with low back pain. First, look for red flags. If red flags are present, arrange urgent evaluation and targeted investigations, including MRI when indicated. If there are no red flags, perform a neurological examination. If the examination is reassuring, conservative management is usually appropriate. So remember these Medmorph pearls. Red flags first. Examine the patient. Don't chase incidental MRI findings. And keep the patient active. But here's the next question. What if Ramesh suddenly developed urinary retention and saddle anesthesia? Could this be called a equine syndrome? That's our next case on Medmorph.